Hello, Dental TV viewers. I'm Dr. Kim Tae-eun, the MC of this case discussion. So we have invited three speakers. First, we have Dr. Jeong Jong from Setmoa Dental Office. Hello, nice to meet you. I'm Jeong Jong. From Samsung Seoul Hospital, we have Professor Yang Seung-in. Hello. And we have Dr. Son Young-hee from Kumpo Lee Dental Office. Hello. In this case discussion, as before, we will discuss cases sent by our viewers and discuss about that. We will introduce and discuss maxillary sinus lift failure cases. Today, let's look at the first case. 55 female patient, no remarkable medical history. The patient, 3 years ago in another dental clinic, she received the sinus lift using a crystal approach and implant placement on the upper left and completed the prosthesis treatment. But number 26 implant migrated into sinus. The two implants placed were attempted to be removed. Regrettably, number 26 migrated deep into the sinus, so it was not removed. This is the CT X-ray. So the fixture has migrated deep into sinus. How can we plan the treatment? It is very frustrating case. Dr. Chung, what do you think? It is really regrettable. Recently, crystal approach tends to be increased more as a sinus lifting. Proportionately, more fixtures are migrating into the maxillary sinus. If you look at the problems here intraorally, I can see oral antral fistula at number 26, and over that, suppuration is coming out after sinus lift with a sinusitis. Oral antral fistula as a complication has occurred. I believe this is a very complicated case. The treatment I'm thinking about is that the number 16 implant in the sinus needs to be removed first and remove the source of infection. After the lesion in the maxillary sinus is eliminated, oral antral fistula is closed, then implants can be placed. How can you remove that fixture? There are broadly two ways to remove the fixture. The most frequent approach would be through the external wall of sinus. The second approach is used a lot in the otorhinolaryngology using an endoscopy. Mostly, lateral window approach can be used to remove it. When an implant is in the sinus, most basic one is to remove it as soon as possible because it can be removed easier. If the patient is lost to follow up or if you're not confident in doing the procedure, as time passes more, the implant will be surrounded by granulation tissue and it is difficult to detect the implant and it will be very challenging to remove it through lateral window approach. Whatever the technique may be, the first priority is to remove the implant. On the CT, it is not exact, but the granulation tissue is surrounding the fixture, right? Yes, it is buried in the soft tissue. It will be challenging to remove it. Dr. Son, have you removed such implants a lot? Not many, but I have experienced it several times. When the implant fixture is dislocated in the sinus, there are two occasions. If it is dislocated during surgery, it's easier to remove it using suction. But if it is dislocated a long time ago, it can be granulation tissue or it can be hypertrophic mucosa. And as Dr. Jeong said, we need to remove it by all means. Preserving bone or soft tissue is not a priority in that case. Removing the implant is the most urgent job. Prosthesis delivered and during use, sinusitis occurred and it is dislocated. I experienced a patient. 3 implants were splinted when crown was made, and the middle implant is dislocated and migrated into sinus. Yes, prosthesis delivered, but that occurred. But the patient did not know what happened and complained a headache. I believe the dentist tried to remove number 26, but it migrated further into sinus. It is a very regrettable situation. Working at a hospital, sometimes I see very surprising cases of patients treated at clinics. The patient with 3-unit bridge was not aware of the migrated fixture, as Dr. Son said. Patients seem not aware of it unless there is a symptom. I had a very similar patient. There was an implant, but it migrated into the sinus. And bridge was delivered to the patient. I was really puzzled whether I should tell the patient or not. And I just told the patient to go to the dental office where the patient received the treatment. I believe you need to honestly tell the patient and let him or her get the treatment as soon as possible. Dr. Chung, I have prepared a similar case to this. I hope this helps. In the upper right, number 16 implant migrated into the maxillary sinus. The implants were placed in another dental office, and the implant was migrated into the maxillary sinus. In this case, it can be removed if it occurred shortly before. A big window, lateral window, is created on the side wall. And the bleeding occurred during the creation of the window. Hemostasis was done using suction. The implant is removed. Inside there is the granulation tissue with a copious irrigation. If necessary, suction can be used during irrigation. And then it is sutured. Secondary healing is being made at least 3 months, and I wait more than 5 months. And you need to confirm the healing on the CT. And then lateral approach can be done as the window was previously made. So periosteum can be adhered to the buccal mucosa and sinus membrane often. So you need to be very careful when you do the dissection to reduce the perforation of sinus membrane. So in the usual way, the window approach is used. Bone graft and implant placement were done simultaneously. Next, post-op pictures. Final prosthesis were delivered. Post-op 5 years. So Dr. Yang gave us very good point. When implant migrates into the sinus, we need to remove it as soon as possible. When we do crescent or window approaches, regularly we need to follow up on the patients. And when we find the migrated implant in the sinus, we need to remove it as soon as possible. If you're not confident about doing the procedure, you need to enlist the help from others, and you need to let the patient know about it to prevent sinusitis or other complications. Dr. Son, this is a really challenging case. When I remove the implants in the sinus, of course, the window needs to be created in the sinus wall. I use this kind of approach to tell whether the removal of implant would be easy or challenging. My approach is I use 2 X-rays taken with some time gap. If the implants in the 2 X-ray images are not in the same position, it's easier to remove. Otherwise, if they're in the same position, it's more challenging to remove. With a strong commitment, I need to enter the site. So, do you let the patient jump? Yes, I let the patient shake his head to take the X-rays. That's a kind of tip. So the 2 images are the same. It would be challenging, right? Yes, adhesion has occurred, the granulation and fibrous tissue is holding it. So direct exploration is required. The simple suction would not work. We need to identify the location of the implant's fixture. It's very challenging. When implant is migrated into the maxillary sinus long time ago, more than 3 months ago, it is sometimes difficult to find the implant. In my case, if that is the case, I take the cone beam CT image to estimate the location of the implant, and using the lateral approach, I focus suction on where the implant is expected to be. If the suction doesn't work, CASE or other long instrument is used for sounding. The sound from the implant and from the sidewall of sinus is different. So that way you can detect the implant and you can remove it with a suction or with a long pincet. Once it is removed, and if it is maintained cleanly inside, I believe half of the job is done. In this case under discussion, when you open the window laterally, what instrument do you use? In general, after opening it laterally, I use the suction tip. Using the negative pressure, it is removed. Therefore, the suction tip should be thick. Suction is switched off on the lateral window, and it is moved into the sinus, and it is turned on. After you rotate it, due to the negative pressure, the implant would be suctioned out. When you create a window, lateral window, you need to make it a little bit big for the instrument. I do similarly. At first, you can get frightened. You tend to make a small window for the sinus lateral approach, but you need to make a big window, and the membrane incision should be in big size. I do not make a small incision, so it should be made big for easy access. If you have a good light, you can see very well the inside. So for good approach, the window is made big and the membrane incision should be big. Rather aggressive incision needs to be made so that we can see well the inside. Still, sometimes we cannot really see inside. So more than 3 months has passed. After the lateral window is made, the sinus membrane is very flabby, so we can enter very easily. In that case, We don't need to be concerned about the membrane. We just focus on removing the implant. And one more thing, after the removal, after the irrigation, the lateral window is created, and do we need to cover it with the observable membrane and suture it? I don't think so. It is a resorbable membrane, so it is covered with the resorbable membrane, and when we do the second lateral window approach, we can work on it. As was discussed during the fixture removal, rather than preserving the bone or soft tissue, removing the implant is more important. We had a very good discussion on case 1. Dr. Son, do you have anything to add? Not really, but if you go into the sinus to remove the implant, you have to remove it, right? No matter what, we need to remove it. Professor Yang? I believe diagnosis is the most important thing. Dr. Song gave us a very good clinical tip. On the panorama, we cannot locate the position exactly, so we need to take the CT image. On the axial view, we need to identify the exact position of the implant. Then we would know in what direction we need to go in the lateral approach. Diagnosis is very important, and we need to make a big access incision or hole. If you are hesitant on where that might be, you will not be able to find the implant. Once you make a good diagnosis and the direction is set, you need to go in there aggressively. Exact position should be identified, and you need to get good operation plan, right? You may not have the long forceps or bayonet forceps. Without them, you cannot really go in there. Yes, many people do not have them. So you need to prepare the instruments in advance. First of all, you should not make the implant go in the sinus. That's right. Even though the implant migrate into the sinus, what we discussed would be very helpful in dealing with the situation. Let's go to the second case. A 66-year-old female, there is medical history of hypertension, and the dentist who raised this issue said that 6 months before, on the left sinus augmentation surgery was conducted and infection occurred. After that, the patient moved to a general hospital and graft material removal was carried out. However, after that, on the left side of the face, discomfort and the induratum is felt. The patient is complaining pain, and the dentist would get nervous hearing that. What is the cause of the pain? How can we get rid of the pain? And if the patient is to receive implant placement in the future, what would be the approach that we can use? Dr. Yang? This is really regrettable. After surgery, infection can occur, but infection gets large and the graft materials need to be removed. As I can see here, it is not completely healed. I believe in the general hospital, graft materials are removed, but still the infection is not brought under control. As was discussed before, oroenteral fistula should be prevented. Depending on the cause, the treatment can be different. Now it looks healed, but the patient complains dull pain or induratum. It is pain after surgery. However, it depends on the magnitude of the pain. The pain can be felt like a chronic pain. We need to give the pain controller. Depending on the patient, some improvement can be made, but in worst case, it can remain as chronic pain. Sometimes we see something called phantom pain. Even though all the causes of the pain is removed, still the patient can feel pain. Even in such cases, we need to follow the basic principles. We need to have dialogue with the patient after the causes are resolved. There's no graft material here only because a thickness is observed and there's no sources of infection here. Over time, things will improve. We need to be patient. We need to talk with the patient. We need to lead the patient. After resolving all the causes of pain, sometimes we need to wait. During surgery, if we invade the nerve, it's a different story. But when the sources of pain are removed and still the patient complains the pain, it will put the dentist under a lot of pressure. Right? Augmentation surgery is a big deal, and removing implant itself is causing a lot of damage. So as you said, during waiting time, what do you prescribe? First, the pain controlling medication can be given. On the CT, I don't see problems, but infection may remain. Therefore, enough antibiotics should be prescribed for the sinus inflammation. If it is not the case, after that, when pain appears, painkiller can be given. Most importantly, the inflammation should be resolved completely. So enough antibiotics should be given, basically for 2 to 4 weeks. In this case, when there is pain, when we do the lateral window approach, hardly intraorbital nerve can be damaged by instruments. But due to infection, indirect damage to nerve can occur. And in the sinus, soft tissue inflammation may remain, so the patient can complain pain. If the sinus inside of it is clean and there's no lesion, it may take some time, but after a certain period of time, unless it's neuralgia, the representative facial pain, other pains may subside. So among the questions, after pain control, if the patient wants to have implant placement, how can we approach that? Dr. Son? So I have prepared a similar case of my patient, 59-year-old male. 5 months before, sinus surgery was performed by another dental office, and the membrane perforation occurred, so surgery was stopped, and the patient was referred to me due to the left sinus infection. When a patient comes to me due to sinus lift failure or infection remaining in the sinus, first I check the sinus ostium patency. If it is blocked, I refer to ENT for FESS. If ostium patency is secured, I administer augmentin for 3 to 4 weeks, and the periodic checkup, CBCT, taking is done. If the membrane is normal, if the thickening has subsided, I do the surgery. That's my protocol. This is my patient. On the left sinus, alveolar ridge is heavily depressed. On the CT, the lateral is open and the membrane thickening is quite severe. So for 4 weeks, augmentin is administered on the top of the CT, you can see decreased thickening. January the 2nd, the sinus is normal, and surgery is done. As you can see, before the membrane elevation, oral mucosa and sinus membrane are adhered to, so if you're not careful, the hole is made. So when they are attached like this, not blunt dissection but sharp dissection using a blade should be done to separate oral mucosa and sinus membrane. Sinus graft is done. Perforated sinus membrane is repaired with collagen. Alveolar process is severely resorbed. Augmentation GBR is done together, and the implant placement is delayed, and the surgery is completed. After that, 2 months post-op, 4 months post-op, implants were placed at 4 and 6. The middle implant, we planned 3 implants, but the middle one was removed because of poor initial stability. 2 months after, September, post-op 5 months, prosthesis delivered. So using the protocol, if you look at the CT, the alveolar bone remodeling, bone graft in the sinus are very well maintained. So following the approach, if the patient has experienced a sinus infection, if possible, we need to wait a little bit longer after sinus lift and the bone graft. I believe that's necessary. If the membrane thickening is not disappearing, you should not do the surgery. After the membrane becomes normal, you need to do the surgery to be safe. The resurgery seems more challenging. Do you have anything else to add? If time allows, I would like to present a similar case. This patient, on the left side, sinus elevation and bone graft was done, but infection occurred. After sinus elevation, infection occurred, and more than 3 months has passed before the patient came to me. On the left sinus, chronic sinusitis is observed. In this case, as Dr. Son said before, sinusitis needs to be addressed. First, the medication is given for 4 to 6 weeks. In most cases, it will subside. If the middle ostium patency is not maintained, despite the antibiotics treatment, FESS can be done if necessary. Fortunately, in this patient, things got better. On the CT, middle ostium patency is maintained. When you take CT, in my case, rather than the ridge height, I look at middle ostium patency, so the CT is taken at a higher level. This is after 3 or 4 months. If you look at the CT, on the lateral side, you can see the bone grafted a long time ago. So after sufficient time, the lateral approach is performed. This is the residual bone from the bone graft performed during the sinus lift a long time ago. As it is removed, the sinus membrane is torn. Using a mesh, a careful incision is made, separating periosteum and the sinus membrane. But as the bone grafted a long time ago is removed, the membrane is torn. For this, like the treatment for sinus membrane tearing, resorbable membrane is used for repair. I use rather stiff resorbable membrane in this case. If it is not stiff, the collagen is flabby, which cannot be fixed. So bone grafting is done. After sufficient time of waiting, we wait 5 or 6 months before placing implants. As Dr. Son said, once the patient had infection there, the bone regeneration patency is decreased. Therefore, we should not hurry. We should take a two-step approach if possible. Bone grafting is done, and after waiting 5 to 6 months, implants can be placed like this. Once the sinusitis is subsided without a problem, I believe we can achieve a good outcome. Thank you very much for the good case. Do you have anything to add? I think what the two doctors said is very important. Once the sinus was infected, I don't know why, but the healing capability is far less than the sinus that has not been infected. It affects the graft material's maturation capability. Therefore, we need to have sufficient healing time because we cannot afford to have the second failure. So we need to give time for the bone material to get osseointegrated. After the stable condition is achieved, we can place implants to be safe, whatever it may be. When we are in a hurry, we need to think step by step to relieve stress on the part of clinicians. We talked about unwanted complications that occur after sinus lifting. If we share good news, we are more happier, and if we share a problem, our stress would be getting lighter. And I hope the discussion will be helpful for you. I would like to thank Dr. Jeong Jong, Professor Yang Seung-min, and Dr. Son Young-hui for the discussion. Thank you very much.
고생 많으셨습니다.
원장님
고생하셨습니다.
감사합니다.
아이고.
고생 많으셨습니다.